very, very interesting course on IOL fixation techniques. So suppose you have a PCR, you do not know what IOL to put. So we want to discuss everything from A to Z. Suppose you are in a dilemma what to do. So that is the main idea or objective of this course. We have the pleasure and honor of having a fantastic keynote speaker for this wonderful session. We would like to thank the AIOS for this wonderful opportunity. I am the Chief Instructor. I am Dr. Mohan Rajan from Chennai, India, and I will be taking you through the course. Along with me is Dr. Ashraf Armia. He is a very, very close friend of ours, and he has attended so many conferences in India. And Ashraf Armia will be giving the keynote address. His topic is a very interesting topic for all of us. It's an IOL exchange dilemma with restoring the pupil structure as well. So today we are talking about how to restore the pupil structure and how to exchange the IOL also. So we'll start with the keynote address. Each of the talks will be about 10 minutes, and then we'll have good time for discussion also. So we'll start this session with the keynote address by Dr. Ashraf. Ashraf, all yours.
Thank you so much.
Thank
you. First of all, thank you so much for the invitation. Thank you for being here in India. Every time I come here, I feel that the same atmosphere is like Egypt for me. A lot of friends here in India. It's more than 10 years, my friends. So let's talk. When they asked me about talk, it's IOL exchange before we go for scale fixation. So if you still have a bag, if you still have a remnant, we are going to change in a difficult situations and how to restore the pupil, because without restoring the pupil, you are not going to do anything. Optically, the patient are not going to be happy, even if you change the refraction of the patients. So I have no financial disclosure regarding to this presentation, but these are my disclosure to companies that I'm a consultant and a speaker to them since years and years. So an IOL exchange is rarely required. Yes, because in modern cataract surgery, usually we are meticulous in choosing the pupil in the IOL now and the site of the pupil. Owing into advances in surgical techniques, IOL design, biometry, everything was changing than the future. The future was really difficult. Nevertheless, IOL explantation and exchange are still sometimes required in certain situations, and you should know how to change. This is important. The first of these are lenticular problems, such as IOL opacification, poor neural adaptation in the premium cataract surgery nowadays, and damaged IOL. The second situation involves ocular problems, such as IOL dislocation, decentration, capsular contraction, and corneal decompensation. Or incorrect IOL power. That's rarely happen nowadays. And without IOL suturing and returning the pupil size, it's difficult to make the patient happy. And when we think about iris repair in these situations, reconstruction, because you are going to reconstruct the pupil to as much as you can to maintain the pupil size. Either we go for pinhole pupiloplasty, as Ammar innovated with his group, or you do the through pupiloplasty, which is in my hand in the last 5 years the easiest way to iris repair nowadays. So let's go for the first case. I am going to present two very nice cases. The first case, it was a female patient, 21 years old, had a congenital cataract. Cataract operation was done with an IOL implantation since 19 years. And since 8 years, the vision drops and she cannot see except 1 meter. Then after cataract, maintained more grow and captured IOL, and the pupillary membranes were seen, and the vision reached just PL with hand motion. No fundus view were seen, but the normal ultrasound photos, and the IOL was wrong calculated, taking this idea from the other eye, which also planned for exchange after this eye. So in this always, in a critical situation, you should put a plan before you go for the surgery. So this was my surgical plan. Either you remove the pupillary membrane, making the captured PMMA IOL free, removal the IOL, cleaning the after cataract, discovering if there is a still posterior capsule or not, and planning for implantation of a foldable IOL if the situation will go through. So let's go for surgery and enjoy the journey of this, because it was not an easy case. So I always think when I do that what I feel inside the eye is different than the slit lamp. These all my challenging cases like this. So with the viscoelastic, it's the best tool to feel the eye. So inject more than viscoelastic and feel what's happening inside. So as I started, I'm trying to dislodge this PMMA lens without much trauma, because it's already there is a trauma and there is a huge adhesions in the tissues. I want to reconstruct the anterior chamber and reach a good size of the pupil. So the first challenge was done, removing this PMMA with the least trauma. But there is a huge, and I discovered that the haptic broken was the cause for captured of the IOL. Viscoelastic, I closed the anterior chamber because manipulating the eye in a closed anterior chamber safer for the eye. Then I'm trying to find a way or a space between this adhesion between the iris tissue and what's behind. It's amalgam. I don't know what's this. Either it's an after cataract, it's anterior capsule, it's a vitreous. I don't know. Really, I don't know. So with the micro forceps, micro instrument, this is important in these cases, like micro scissor, I'm trying to create or find again the sulcus level. So it takes time, it takes time. These cases, I make it in the last set of my list to enjoy, because this is a time, you cannot put the time. So I'm trying to find this amalgam. This is a huge after cataract. You can see how it's bigger, and it cannot be by AA. It's very difficult to take it by the IA. So I express it and express more, and now I can see the red reflex for the first time. But seeing the red reflex, I'm trying also to remove this after cataract. It's very difficult by the IA or even by the ocuotome. I introduced the ocuotome, but I couldn't. So I open, remove, visco expression. Now I'm dealing with the case. Now I'm seeing red reflex, but red reflex means either there is a posterior capsule, open posterior capsule, there is no bag, I don't know. So I'm trying again to find a space, because I need an IOL to be placed inside. And I rarely go for scalar fixation unless I lose the bag. I do whatever I do to preserve the bag, because I believe that it is the physiological place for the IOL. So I felt now that I may lose the bag, so I put my plan for Yamani, but still I'm hoping for the bag. Again, I'm trying to polish this with the ocuotome, because I felt that there is no bag, very posterior capsule, but surprisingly, that it was the bag, and it was the posterior capsule fibrosed. So strange for me. So I changed my hand from the ocuotome to IA. So I'm trying to remove all the cortex inside the old bag. The old bag is, I could open the bag now, and removing all the cortex inside the bag. And this line is just a fibrosed posterior capsule. And I succeeded to implant single piece IOL inside the bag in this case. It was for me so strange, because I planned already for a Yamani. And then I restored the pupil, because you cannot leave the pupil like this. I did a 4-through pupilloplasty to maintain the pupil size again to its normal level as much as I can. 4-through is the easiest way for me. I can repair the pupil easily. Take your time, because don't stretch too much, because it's already fibrosed iris. You don't need iris trauma to the angle. You don't need iris insertion. And this is how it looks pre-operative and post-operatively. And the patient improves a lot after surgery. The second case, it was also a weird case. It was a male patient, 28 years old, trauma since 15 years, cataract removal and IOL was done, picture of multiple peripheral anterior synechia, and with iris incarceration in angle, captured dilated pupil. The plan. Very important to put your plan to prepare your instrument. Either IOL exchange, 3-piece IOL in the sulcus, iris repair, IOL exchange, retropupillary artisan, iris repair, IOL exchange, 3-piece IOL with any method of scleral fixation and iris repair. Let's start the surgery. Again, my instrument is a viscoelastic. The viscoelastic is the best way to feel the eye inside. Still clamp something, and what inside the eye is another area or another scope. So I'm trying also to remove this very captured, incarcerated IOL in the eye. Take your time to make less trauma. So with much manipulations, I succeeded to remove it from the incarceration, bring it with cutting of the peripheral anterior synechia, because I want to anterior reconstruct the eye, anterior chamber reconstruction. So more and more till I succeeded to bring the IOL outside the eye and removal of the broken haptic. That was the cause of the tilting or pupil incarceration. Now I'm trying to milk the iris and also to find a space, because I like the sulcus. I will maintain the bag also, in spite the posterior capsule is not present. There is a vitreous. I did a posterior anterior vitrectomy for the case, but I'm trying to open a space in the sulcus because I think that I'm going to succeed to implant in the sulcus. So more and more manipulation, more and more delicate opening adhesion between the iris and the anterior capsule, you can succeed. Take your time. Don't feel that you are going to lose the case. Don't feel like this. You can do even in a very difficult cases. Now I open totally the sulcus. I succeed to put a 3-piece IOL in the sulcus, in the physiological place. And then once I finished, I will not going to leave the pupil like this. I'm trying to milk the iris to find a good tissue for iris repair. Again, with the 4-through pupilloplasty, I can take the iris in a proper way. I can take the other side and trying to restore the pupil size. And in any place in the cornea, as you all see, bring the loop and do the 4-through pupilloplasty. Again, I did here, I did the other side, till I restore the pupil size of the patient to nearly a good size pupil. Finally, this is how it looks. This is how it looks before the -12 diopters. Now the patient is -1 diopter after removal of the sutures. So my take-home message, don't lose hope in surgery. This is very important. Don't complicate the way when you are dealing with a challenging case. Put all your plans in your mind before surgery. Very important. Don't raise the expectation of the patient. These cases, you cannot tell the patient, you are going to be wow. No, we are going to do the best for you, but we cannot give you hope, too much hope. Always prepare all your tools because you already planned for the surgery. Surgical techniques for iris rehabilitation is mandatory. You should know and learn. Successful iris repair. 4-through is one of the best tools. And always remember this. You are braver than you believe, stronger than you seem, and smarter than you think. This is how we are already, every one of you have this. But you should enrich this inside you. Thank you so much.
Oh, beautiful. Very nice, Ashraf, for the opening keynote address. I think it was very nice, especially I like the last slide. It was very nice. And we'll have the discussion at the end of the... Ashraf, please come here. Occupy the seat on the dais. So, as you know, this course we have been doing not only in APAO for so many years, but also ASCRS, ESCRS, American Academy as well. I have to thank my guru, Amar Agarwal, for the wonderful innovations, what you have done, so glued IOL. So what we are going to do is, I'm going to talk about after PCR what next, and Amar Agarwal will be talking about glued IOL. Sujata will be talking next on suture scleral fixation, and then followed by Amar Agarwal, and then Nivian, and then Dr. Ravi Shankar. So we're going to cover everything, and we'll have a good time for discussion so that you can clear all your doubts. So these are my financial interests. Early recognition combined with advanced instrumentation enable effective management of posterior capsule rupture. Anybody who has not had PCR at all in this audience? Anybody has not had PCR at all? So anticipate PCR and traumatic cataracts, post-vitrectomy, posterior polar cataracts, brown cataracts, pseudo-exfoliation. So a couple of years back, I was presenting in Amritsar when Sardarji put up his hand and said, I have not had PCR. Then we found he was an ENT surgeon, Amar, because he came that because his wife was an ophthalmologist. So only if you are an ENT surgeon, you will not have PCR. So options available is that IOL in the bag, IOL in the sulcus, ACIOL, iris claw, SFIOL, Yamane, so many other ways to skin the cat. Ashraf was talking about some IOL exchange and beautiful pupillary reconstruction as well. And then, of course, we're going to focus on group. See, if you understand this animation, okay, this animation is the most important thing. When you have PCR, okay, if you have coaxial irrigation aspiration, coaxial means the irrigation and aspiration are in the same port. That will enlarge the PCR and the PC rent will become more and more vitreous will start coming into the anterior chamber. Vitreous is like a tsunami. So once you hydrate the vitreous, it will come up. But if you have bimanual means the irrigation is separated from the aspiration, the irrigation is separated from the cutter, okay, then you can tamponade the break and prevent the hydration of vitreous. Whatever vitreous is there in anterior chamber, you can connect it. You can see here, this is one of my phaco trainees, you can see the date also, 2007. This is what happens to everybody, okay. So when you have a PCR, you can see what's happening, okay. You become jittery, you may be operating on a VAP or a doctor or something. Because only for VAPs the PCR will occur. So there's a problem. So what is important is do not pull out of the eye. Do not pull out of the eye. That's very important. If you pull out of the eye, what will happen? The PCR will become more vitreous. Then immediately I went in and did a bimanual vitrectomy. Always remove the vitreous first and then remove the cortex and the epinucleus. What will happen to the nucleus which has gone behind? Depending on the karma we have done. If you have done good karma, pray to God, and then you have done good karma. See what the nucleus is coming. Beautifully it's coming. So it's coming up and then you can see. Ideally you have to do a pars plana vitrectomy and go in. So I can see this is another one of the former union. At that time he was a union minister in 2003. See what's happening. These politicians commit a lot of sin and then they come to you and you can see here what happens. When the PC tear occurs, it's because the post-occlusion surge. Okay, I don't lose my calm. I don't withdraw my phaco probe suddenly or abruptly. I inject viscoat. The viscoat is something which is probably the best product of Alcon. Alcon is not paying me a single paisa. I'm telling you, the viscoat will go and plug the PC tear. It will go and plug the PC tear and then immediately you shift to the right side port and go for the bimanual. Go for the bimanual irrigation aspiration. Whenever you come out of the eye, inject viscoat. Okay, so the PC tear does not enlarge. So remove the vitreous. At that time the tricot was not available with us. But nowadays you should use tricot. I will show you this thing. This is a post-operative picture. Again you can see here this is a patient. This is a gynecologist who came from Kerala, the neighboring state. She wanted a toric lens. The lens started going inside. I did an anterior assisted levitation of the lens and then went ahead and put the lens in the sulcus. So you can see here I'm putting a lens in the sulcus fixation. You can see this is a hydro rupture. You can see what is happening. Can anybody tell me what is the mistake I'm doing? I'm doing a multi-quadrant hydro dissection. See what's happening. Top it opens up. Why it opens up? Because every time you do a hydro dissection, you have to decompress the nucleus into the bag. Otherwise what will happen? The pressure will start building up in the posterior space between the nucleus and the posterior capsule and it will open up. As soon as I put the phaco probe, what happened to the nucleus went inside, said tata bye bye. Okay, so you can see a posterior polar cataract. One of the ophthalmologists who came to me from Tamil Nadu in a place in Tamil Nadu, you can see I did a fairly okay rexus. Okay, about 5 millimeter rexus. Don't do a hydro delineation. There are 3 conditions. Don't do hydro dissection. One is a posterior polar cataract, another is a traumatic cataract, another post vitrectomy. Nowadays we have patients who have multiple injections of Lucentis or Avastin into the eye. You can see what's happening now. So I'm taking the epinucleus and taking. So far so good, I was telling him everything going on well. See suddenly what's happening. This is the problem with the posterior polar cataract. It is not a PCR, it's a PC dehiscence. There is a congenital dehiscence. You can see the two pillars on the posterior capsule. Inject viscode, go bimanual, then immediately put tricot, dilute tricot 1:4. Even God cannot see vitreous without tricot in the anterior chamber. Please understand this. Put tricot. Don't put too much tricot, don't put too less. A good amount of tricot, a fairly good amount, which will delineate the vitreous so that you can remove the vitreous, and always do bimanual vitrectomy. Don't use sponges, don't use devicus, don't pull the vitreous. You can go past plana also, you can go limbal also, whatever you are using. And then go ahead and inject, you can see another patient with the posterior polar cataract, you can see PC. Sudden deepening of the anterior and posterior chamber, and immediately inject viscode. Don't pull out of the eye, inject viscode. Create right side port. Don't use the main port. Create right side port. Do an anterior vitrectomy. Put tricot. This keep it in your mind always. At that time when you become jittery, when your adrenaline is flowing, you'll forget everything. Okay? And you can see here. So what is this thing? You put a sulcus, lens in the sulcus. Don't leave it in the sulcus. Okay? This is a haptic 3-piece lens in a posterior polar cataract. Obviously you can put a lens, can't put a lens in the bag. If you leave it in the sulcus, what will happen is, it will decenter. You see, you can see here, this is called the optic capture. The haptic goes into the sulcus, the optic is captured into the capsular rhexis margin. Okay, this is called the locking of the lens. If you lock the lens will not move a micron. The lens will not decenter. Otherwise, you keep it in the sulcus, the problem is they can decenter, they can produce UGH syndrome. The end point of the locking is the ovalization of the anterior capsular rhexis margin. That is the capsular rhexis margin. You can see this lens will not move a micron. You can see the postoperative pictures as well. If the small PC tear convert into a posterior capsular rhexis, because the posterior capsular rhexis is much more stronger, then you can go ahead with this thing. You can see here this is a slightly bigger PC tear. I am not able to convert to the rhexis. I went ahead and put a lens. See what's happening now. So if you have a PC tear like this, it's extending to the equator, very difficult to do a posterior capsular rhexis. So immediately I put viscode, you can see how this thing is there. But once I put a single piece lens into the bag, see what's happening to that tear. Okay, I'm injecting viscode every time I come out of the eye. This is the thing you should cover. Every time you come out of the eye, whatever viscoelastic, if you don't have viscode, doesn't matter. You can put HPMC, whatever viscoelastic you have. See, don't allow the chamber to collapse, very important. When you have PC tear, see what is happening now. Because I have not converted that into a posterior capsular rhexis, there is a single piece lens which is going into the bag. You see how the tear is enlarging. Fortunately for me, the lens is quite stable. I left it like that and prayed to God, and patient did very well. Okay, you can see a femto patient. This is just because you got femto everything, it doesn't mean you have the problem. This is something which I learned from my Guru Amar here. You can see here what is happening. This is a thing. When you have a PC tear, what happens is the pupil becomes small. You do not know where your sulcus is. Then you put a lens in a small pupil. The lens will go, one haptic will go underneath the rhexis margin, and the other haptic will go in front of the rhexis margin. Okay, and then next day you find the lens on the macula. Okay, but I'm just telling you. So just put iris hooks. Take that extra time. Put iris hooks. Then see the sulcus properly. See the periphery properly before you put a lens. That's again very, very important for you. Take that extra time. If you are in, so always in a posterior polar cataract, if you have mature cataract, do not know, look at the fellow eye. The fellow eye has got an AC IOL or a glued IOL or an IOL in the sulcus. I always give a high index of suspicion for these patients that these patients have got a posterior polar cataract. This is a posterior polar cataract. Can see here what's happening. I'm doing a femto for this patient, and this is a young patient. Other eye I didn't see. One of my associates, they didn't even look at the other eye. Other eye had a lens in the sulcus, and I just like that all mature cataracts I do. So you can see what's happening. As I'm removing the nucleus, there is a huge, it's not actually a PC rent. It's a PC dehiscence. It's like two pillars on the PC. You can see the PC does not join there. So inject visco and then come out of the eye, bimanual IA, then put a lens, 3-piece lens into the sulcus and then capture it. Again, you can see here. So management is traumatic subluxated cataracts, all this, because I'm running out of time now, anterior levitation, and put an ACIOL. Very rarely we do that also. The patient is got a very old patient, and this is a posterior levitation. Retro-iris claw lens, I think Nivian is going to talk about it, that, and nucleus drop and other things, and scleral fixation lens. I'll go through it very fast because all these are being covered. The take-home message, PPP or preferred practice protocols in PCR. Small PCR convert into PCC. Do not pull out of the eye, inject viscoat. Use tricot preservative-free, 1:4 dilution. Bimanual anterior vitrectomy, limbal or pars plana. Remove the vitreous first and then remove the cortex and the epinucleus. Appropriate IOL. You can leave them even aphakic if you are noticing them. And consider maybe a glued IOL or something like that, or IOL in the sulcus. After a couple of weeks, when the fibrosis of the capsule also occurs, you are in a better frame of mind to examine the patient on the slit lamp, and then always suture the wounds. Why suture the wounds? Because please understand, when there is a vitreous loss, the incidence of endophthalmitis goes up by about 5 times. So I don't want any micro leaks or anything. So ACIOL, retro-iris, sutured, glued, all these are going to be covered in this course. I thought I'll just give a introduction for the whole thing. Sulcus IOL, Yamane technique, and thank you very much. And please make a note of this calendar, 37th APCRS meeting in August in Ahmedabad. Thank you. We have Dr. Sujata Mohan, Associate Medical Director of Rajanekar Hospital, and she's going to talk to us on fixing
dislocated
management of subluxated IOLs. I've been to know fixation, most of the external fixation. Yeah.
Thank you, Dr. Mohan. I'd like to thank APAO and AIOS for this wonderful opportunity. I'm just going to show you some case scenarios in which we have fixated wobbly IOLs or dislocated IOLs. So case 1 was a 70-year-old male who had a phaco foldable done 15 years back by us, had excellent vision of 6/6, no history of trauma, but he complained of oscillopsia or some shaking vision, and on examination he had pseudo exfoliation. You can see the video here showing that how the lens is moving. This is you can see that's a multi-piece lens. It was even before the era of foldable lenses. So we decided to fixate the same lens and prepare the eye to receive to convert this lens into a glued IOL. So you can see I'm using a posterior infusion. Also, I'm having I've already made 2 flaps, made the Chariot's pockets. Now what I'm doing is I'm lifting the lens out of its position. You can see how easily it is coming out. Absolutely, there are no zonules. But it's very important that it doesn't fall into the vitreous. So you have to very carefully place it on top of the iris. I'm trying to remove the capsule, but it's not possible. So I'm going to use a vitrector to remove the posterior aspect of the capsule. So basically, we want to remove the lens out of the bag. So initially what I'm doing is I'm just creating a posterior capsule, just eating away the posterior capsule. And now I'm just feeding the lens into the what is called as a handshake technique. I've just exteriorized one haptic. At the same time, I'm holding the lens on the other side, and you can see now I'm exteriorizing the other haptic. So there are some remnants of capsule still present, which has to be removed using a vitrector. In this case, we didn't have any vitreous loss, but I did use a vitrector because I had to remove all the capsular remnants. So now the lens has been tucked into the Chariot's pocket, and I'm doing a minimal vitrectomy to remove all the capsular remnants, and after that the case is closed. So this is a post-operative video of the same patient. This is after the glue has been placed and the flap and the conjunctiva is glued. This is the post-operative video of the same patient. You can see that On movement of the eye, there is no movement of the IOL, and he regained his 6/6 vision and he was very comfortable with it. We have almost about 7-8 years of follow-up with this patient, and he's doing very well. So the next case is a very similar case, again a 75-year-old male with a drop in vision which is worsening over a period of 2 months, and we found this was a dislocated IOL back complex, and this was a single piece lens, and you can see that the lens haptic optic junction is seen in the visual axis itself. So in this case, I decided to go in for a Hoffman's pockets. So just to give us a brief explanation about Hoffman's pockets. So you can see that here I've created, there is a incision which has been created here, and a scleral pocket approximately about 300 to 400 microns depth is made from the corneal side. So you're not opening the conjunctiva. There's always a risk of bleeding. Then you make 2 across each other. You can make it a 3 and 9 o'clock position. And after that, you introduce a 26 gauge needle and thread the 10-0 polypropylene through it. One of the sutures go on top of the haptic, the other one goes below the haptic. You can see that. So a nice loop is formed, and this is done on either side. So when you pull the lenses together, it comes to the center. So this is so finally what you do is you retrieve the suture from under the pocket and tie it. So this is how a Hoffman's pocket is created, and I'll show you the video. So this here you can see I'm creating a Hoffman's pocket, and the most important thing is while creating the pocket you have to make sure that you have adequate space. If you don't have adequate space, then you might be inadvertently putting the needle through an area where there is no pocket. So you have to check the pocket. Now I'm making a you can see I'm going through with a 27 gauge needle, and I'm threading the 10-0 polypropylene into it, railroading it, and I've made one loop. Now the second end of the needle is going, which is going on top. The first one went underneath, the other one goes on top, whichever way you want, and you can see the lens is being pulled towards one side, and now you leave it like that. You just trim the sutures and leave it like that. You can tie it at a later date. So now you can come to the other end of the haptic. So here in this case, what I have done is, so you can see again, this is going at the bottom. So you have to do exactly the reverse of what you did on the other side. That is, if you put on top first, then this one comes at the bottom. So again, the next one is going on top of the haptic, and it's railroaded, and now you have a loop around the haptic on both sides, which is exteriorized, and once you adjust the lens, you can just tie it together. You adjust the lens so that you make sure that it's in the center. Always whenever you do even if there is no vitreous presentation, it's always better to check for vitreous presentation in these cases, and you can put some tricot and check for the vitreous presentation and then complete the case. In this case, I was planning for a glued IOL but converted into this, so I used the glue to seal the pockets, but that's absolutely not required. So this is again a third case where the patient had lens fixated 3 times, because there is definitely a rim of capsule all around, but every time it was fixated, I think it decentered, because either it was not placed properly, or the capsule was not strong enough, or the space was not good enough. So this time we decided that we will do a glued IOL, because patient wanted to end off, and he said, I have come to you because I want a complete solution to this problem. You can see that I'm removing the capsular contents, and you can see the handshake technique where the haptics are being exteriorized using a MST forceps, and again the other side it's being exteriorized. In this case, I'm using an AC maintainer. It's very important, either use an AC maintainer or use a posterior infusion. You need to have an infusion on, and now it's tucked into the Chariot's pockets. A little bit of iris prolapse, actually you really don't have to worry about. You can always tuck it back in, and you're going to anyway glue the flap. And the glue is, and the procedure is completed, and the patient again has a follow-up of about 7-8 years. The last case I'm going to show you is where I have used a slightly different technique. I did start with doing a glued IOL, but then I decided let me use a Gore-Tex suture to reposition the lens, because this patient also has a single piece lens. So single piece lens, if you're going to, you can't glue it, so you'll have to remove it and then replace it with another IOL. So in this case, I decided, let me do a Gore-Tex suture fixation, because that is much more stronger than tensor polypropylene, which can erode over a period of time and again cause dislocation. So Gore-Tex sutures are being used widely now for this type of procedures. So you can see I'm just taking the Gore-Tex suture and retrieving it from under the haptic. So the one portion of the Gore-Tex suture goes under the haptic, the other one goes on top. So you have to make a myringotomy incision because it's a slightly larger suture, it is very thick, and it has to be, you have to make a larger incision. The same thing is repeated on this side. The first one goes on top, the second one goes to the bottom, so that there is no torque of the lens, that a lens doesn't twist. Now that you've got both of them outside, you center them well, and then you do the tying. So you just tie it. You can rotate the knots into position, but if you have not made a flap, you can, otherwise you can just leave it and glue the flap. So in this, you can see that it is very nicely done. And there is a large soldering ring there which has to be removed. And so that's what I'm like I told you, we do put tricord to see if there is any remnant vitreous or some vitreous presentation. And once we got the soldering rings out, we did a anterior vitrectomy and removed, using a vitrector, we removed the soldering ring. And I'm just checking to see if there's any vitreous and just tightening the sutures. You can actually, it will be better to bury these sutures because they are very big and the knots can be quite big, but because it's under the flap, it's okay. So now I've glued the flap and also the conjunctiva, and the procedure is complete. So the summarizing, dislocated IOLs can be managed in many ways. Techniques depends on the surgeon's expertise, the type of IOL, and the complexity of the case. Thank you.
Thank you, Sujata. I think wonderful videos and a very nice explanation and how to do the ab-internal fixation, either sutures or Gore-Tex and or glued IOL techniques. I think it's it's not very difficult. Everybody can do this technique. It's only certain basic protocols have to be followed. And next I invite, I would call him the superstar, Dr. Amar Agarwal. Amar will be speaking to us on the glued IOL and various situations of glued IOL. And as you all know, Amar is a great inventor, innovator, and above all a fantastic surgeon as well. So he's going to talk to us on this different what do you call indications for glued IOL.
Thank you very much, Mohan Rajan, and I think Mohan, Sujata, they're doing such a phenomenal job in their hospital. So let me show you a couple of cases I thought I'll show you. The first thing I thought I'll show you is a case, I called it the triad. So this has got microcornea, there is aphakia, and there's soldering ring. Why am I specifying all this microcornea? Take this particular case, has 3 problems in the patient. Now measure the white to white. Look at that, it's about 8 millimeters white to white. The point I'm making is, if you put a normal IOL, let's say there's no PCR, even if you put it in the bag, it's a foldable, is about 12.5, or even you put a 13 millimeter lens, it becomes crumpled up. It's like a fetus in a womb. So in such cases, the only solution is, if you do in microcornea 7 millimeter eye, you have to do either a glued or a Yamane or something like that, because the optic is inside the eye, the haptic will be outside. We published this in 2015. Now in this case, we are using a trocar AC maintainer. Look at that. That's 25 gauge Alcon trocar. It's above the iris. Please understand, in a microcornea, again remember, I do not know where the pars plana is. So you're always safer with a trocar AC maintainer, and we published this in the year 2016 on the TSCM. So idea of the trocar AC maintainer is this, that's above the iris. If you use an AC maintainer, yes, but again you make an incision, then you push it inside, you do not know if it's too large, too small. If you put a pars plana, you can go into a choroidal detachment, you can get a bleed, choroidal hemorrhage, retinotomy, anything can happen. Now once you have done that, now I'm making my sclerotomies. Now remember, the second problem here is soldering ring. The problem in soldering rings are, one, they can produce an IOL tilt. Second problem, they can fall down. 3, they can produce an inflammation. So the question is, can we leave them behind? No, remove them. Now, when there is no capsule, how will you remove them? See, in this case, the sombering ring has fallen down. I have to lift it, bring it out manually. It's a headache. Not that we cannot do, but we can do it. So we published in 2013 the IOL scaffold technique. Now, we use the principle of the scaffold and the glued IOL, combine them together to solve the sombering ring in cases without capsule. Remember, I have to put in scaffold, means I have to create a capsule of my own. But where will I put the scaffold? I have to go behind the sombering ring. I cannot go in front of the sombering ring, obviously. If I go behind the sombering ring, there's no capsule, there's no iris. So the only way you can do it is, if you do a glued IOL, use the glued IOL as a scaffold. So see this animation, I'm making the glued IOL. Now this glued IOL works like a scaffold. Now what I do is enlarge it with iris hooks, break the additions between the sombering ring and the periphery, bring them to the center, now emulsify this, and that is game, set and match. So in this particular case, that's the way I would like to do it. And we published this in the year 2015. I'm enlarging the iris, the pupillary, the defect some more. Look at this case, another case, but here I'm showing you a mistake. I'm doing the scaffold, trying to create, but look at the mistake. I'm doing above the sombering ring. Array, how can I ever remove the sombering ring if my IOL scaffold is above the sombering ring? So I have to go behind the sombering ring. So now you see, I'm catching the haptic, going behind the sombering ring. Now one haptic is out. Now I'll do the handshake technique. You see that? Once I do the handshake technique, I'll transfer haptic from one hand to the other, catch the tip of the haptic, externalize. Now remember, it's a microcornea, 7-8 millimeters, 6 millimeters is occupied. Cut the haptic, because it's obviously a lot of haptic externalized. Tuck it inside in the chariot's pocket. So far, so good. Now remember, now you got to work on the sombering ring. So what I do is dilate it with iris hooks. Break the addition like I showed you in the animation. Bring it to the center. This sombering ring now cannot fall down. The IOL is there. That means you have created your own posterior capsule. Once you have done that, now you can very nicely emulsify it. You can burp it out. Soon Fixie has brought out a cartridge to suck it out. Any technique you can do. But remember, the first is to do the glued IOL or a Yamane scaffold technique. If you don't have that, the chances of the sombering ring falling down becomes very high. Now remember this patient, these patients will by and large have nystagmus also. This is how the case looks when it's completed. These are the steps of the surgery which I have shown you basically here. This is the patient post-op day 2. Remember, 8 millimeter white to white cornea, 1 week post-op, vision is 636. So the idea here, what I wanted to show you, 1 was a microcornea, 2 the aphakia, 3 the sombering ring, 4th I was trying to show you the IOL acting as a scaffold, and then we can emulsify the sombering ring. Now I thought I'll show you one more case and then I'll give it to the next speaker. This particular case came to me from Philippines. Okay, so this was the case, and my beloved wife comes to me and says, listen, this case has come from Philippines, please fix it. I said, hello, you're joking, what fix it? I can't see what's inside the eye even. How will I fix this eye? So she said, no, I don't know what you do, but fix it. So I'm now taking up this patient. She said, the top doctor from Philippines has sent you. He's got 10 more cases like this to send you. I said, listen, I lost 6 months of my life. If I operate this case, you'll not have a husband soon. So now anyway, I fixed my trocar AC meter because I do not know where the passment again situation is. But look at that. There is something moving there. Okay, I still cannot see. I'm using an endometer from outside. I still am not seeing. So if you are not seeing, please understand, even I'm not seeing. I'm doing vitrectomy. So I said the only way is I take my endometer, put it inside the eye. Now you see an iris claw lens. One haptic is stuck to the iris, one is dangling down there. So using one hand, I've caught that IOL. Using in one hand, I've got an endometer, other hand, I've got the forceps. I'll now gradually bring that IOL anteriorly. I have to make a scleral tunnel. Don't make a clear corneal incision. You are again going to create an extra astigmatism which is of no use to you. So make a scleral tunnel incision. Now catch that iris claw lens, and gradually bring it out. Remember, I have to dislodge it from the iris on the side where it is still stuck. Once that's done, now I go to the glued IOL. So why I'm showing you this case is, I already have a large incision. I can use the glued IOL as a non-foldable IOL. I don't need to inject it inside because I already have extended the incision, catch one haptic, bring one haptic out. Now I go in, do the second haptic. Again, look at the handshake technique which I am doing. Bring the second haptic out. Once I brought both the haptics out, you see I've transferred it from one hand to the other. It's very hazy, the view. But the beauty of the glued IOL is you can still manage with someone using an endometer from outside, and you can see how I'm shifting it from one hand to the other through this very hazy, bad cornea. But still, I'm catching that haptic and externalizing it. Okay, so far so good, case not over. Now I have to repair that iris. So ladies and gentlemen, the technique we tend to use, as Ashraf and others showed, is the fourth row pupiloplasty. Here I've created the Chariot's tunnel using the 26 gauge needle. So here once one haptic is gone in, now the second haptic is tucked inside. Now I start working on the fourth row pupiloplasty. So I take the needle, simple way, through the clear cornea. On the other side, a paracentesis, use a 26 or a 30 gauge needle through the iris. See how floppy the iris is. Railroad the two, bring the loop out. Now remember the number 4, on pull on either side and close it. Now look, one side I have done. I have to do on the other side. Remember, patient has come from Philippines. There's no way he's going to come back to me. I have to make him all right and send him back in one shot. Now when I started doing the other side, I'm just not seeing. Okay, I'm not able to even see the suture, even with the endometer. So I said, listen, stop. Now let me do one thing. Take off the desmoid endothelium complex. See how fibrotic the tissue is. It is so bad, this fibrotic membrane, it is even stuck to the iris. See how it is stuck to the iris. So now I hold with one hand the membrane, and with the other hand, a vitrectomy probe is cutting the additions between the membrane and the iris. Once that's done, my visualization is improving. See that trocar AC maintainer is there, which you are seeing with the blue coloration trocar AC maintainer. So I've got a continuous flow of fluid inside the eye. Now I continue to do my fourth row pupiloplasty. It's quite badly traumatized the iris, but please understand, as much as possible, try to repair it. Also look at the Purkinje image P1. That's what you got to be concentrating on to see that it should be bang centered on the pupil as much as possible. So you see the Purkinje image, it's pretty good. But look, there's an iridiolysis also on the top, if you see. Okay, so now I'm wondering, the technique which tend to use is the trocar assisted iridiolysis. Wherever the dialysis is, right opposite I fixed a trocar. Now take a double arm Proli needle. Okay, pass it through the iris, bring out through the sclera. Now this is a double arm. Remember, when you pull like this, the two double arms, it will repair the iris. So the iridiolysis can get repaired. Now remember, the cornea is bad. Desmoid endothelium gone. So now I do the PDEC. We use the pre-desmoid endothelial keratopathy. We don't do DMEC and DSEC. The reason is very simple. One, I use only young donors. We don't get rebubblings. Normally, in peer-reviewed literature, DMEX will show about 20 to 30% rebubblings or redetachments. In PDEC, we have less, about 3% only. Another issue is, you can manipulate the graph very easily. So here you have created a type 1 bubble. Just to complete this case, we'll just show you the ending of this case. I prepare my PDEC graph, inject it inside. Now let's see how the patient does at the end of the day. So in this case, what did we do? We took out the iris claw lens. We fixed the glued IOL. We did the fourth row pupiloplasty with the trocar assisted iridiolysis, ended with PDEC, post-op day 4. And now you can see the patient pre-op, post-op 2 weeks, vision improved to 612. So I'd like to thank Mohan and Sujata for inviting me for this course. I'd like to thank all of you, ladies and gentlemen, once again. Thank you.
That was incredible stuff, Amar, as usual, and very complicated cases. You made it so look very simple. I'm sure all of you have a lot of questions, but we'll take the discussion at the end. Amar, I suppose you can stay back for some more time. Yeah, sorry. You have to go now? Huh? Yeah. Any questions for Amar before he leaves the room for another course? Any questions for Amar? How many of you are doing glued IOLs here regularly? How many of you are doing sutured scleral fixation? How many of you are doing iris claw lens? Good number in iris claw lens. And yeah, how many of you are not doing any lens at all? That's also a good number. Anyway, we go on to Dr. Nivian Madhivanan. Nivian is, I would say, the rising star of Indian ophthalmology, and he has got several innovations. Fantastic surgeon, both anterior and posterior segment surgery from MNI Hospital, Chennai, and he is going to talk to us on secondary IOL, that is the iris claw lens, and also his own innovation, which is called the CMT Flex lens. Nivian, all yours.
Thank you, sir, for those kind words. So, respected teachers, senior ophthalmologists, my dear friends, so I'm going to talk about first the retropupillary iris claw lenses, and then new innovation, that's a CMT Flex IOL for aphakia. So, I already saw a lot of hands raised. So, these iris claw lenses were invented by Wurst. He was inspired by those lobster claw. So, it's a relatively simple design. It's a single piece lens, no additional loops. So, basically, it works on the mechanism of enclaving the iris tissue. Two instruments that are very key are the forceps that are used to hold the lens, because basically it has to be slightly broad, because these lenses, when you're trying to clip, when you use the regular IOL forceps, it can slip. So we have the crocodile forceps or the iris claw forceps. It's got a broad tooth, so it gives you a firm grip. And also always check sometimes, because sometimes the area is not fully cut through. I have had many incidences where you've gone inside and then you're multiple times attempting it, and that can cause damage to the iris. So just check the lens and make sure where you're going to clip before you put it into the eye. So we'll just go through the first case scenario. As already described, for any of these secondary IOLs, the most important thing is the vitrectomy, anterior vitrectomy. Make sure you clear the vitreous before implanting these lenses. Since it's a rigid lens, we make a sclerocorneal tunnel. As you can see here, that where you're going to clip that 180 degree, even an iris claw. You can do it anywhere you want, but make sure you have the 180 degrees entry. Once you stain, I always prefer to stain and wash it. You can see the amount of vitreous stand. Even though it didn't look in the starting of the case, it looked like a round pupil. It was all good, but then once you stain, you see the vitreous. So you can use a side port. This particularly I've used the trocar, but you can use an AC maintainer or have the infusion through your side port and the 23 gauge or 20 gauge cutter that comes with most phaco machines. So once a thorough anterior vitrectomy is done, and make sure all the strands are clear, make sure the viscoelastic is put to, and make sure you position the lens where you want to clip. The second tip here is I usually take my second instrument also inside first to the mid periphery of the iris where I'm going to clip, and then take the lens inside. So by this what happens is I know exactly where I'm going to clip, and that's where I'm actually taking the lens. The second thing is your right hand has to move up and your left hand goes down. So this happens simultaneously. So when this happens simultaneously, you see the tug and you can see a small dimple that happens. So it's going on to the other side. Again, the firm grip in the center is very important. My second instrument is already there in the mid periphery. Why? Because sometimes if we go anterior, that is when you get this cat eyes kind of pupil, and sometimes if you go too posterior, you can damage the roots and cause bleeding. So again, I'll just show you in slow motion in this video again here. So making sure the firm grip, my second instrument is already inside, and then take it to where you want to clip. Yes. And that movement of one hand going up and the other hand going down. So there, just going inside, making sure you know where you're going to clip, because when you push your lens, you can actually see that iris lifting up. So that makes it easier, and you don't have to give too much of force actually. It is just some amount of partial tissue that gets enclaved here, and you don't have to have the entire iris tissue going inside. And you do get nice round pupils and moderate amount of dilatation to see the post-op fundus, because there was a lot of debate compared to the other lenses. So, and you can use these lenses also vertically also, because this was a case where it was a long-standing aphakia with glaucoma. So the glaucoma surgeon did the trab superiorly. So we had to shift temporally to make the tunnel and do the claw lenses. So here in these types of, sometimes you get these rigid pupils due to long-standing aphakia. So here again, don't be forcefully going inside, because that can damage the iris and we have had bleeding. So what I do is, once you hold the lens here, use your second instrument to guide the lens under the iris just by stretching the iris, because I have a lot of instances where people try to just push the lens down below the iris, and that can cause damage to the iris and cause bleeding. So just use your second instruments, you guide it and then go inside and then clip it. And as a routine, we have a large publication on the long-term follow-ups of these claw lenses. We do not, the incidence of glaucoma was comparable to other SFIOL, so we don't routinely do PI. That was another question raised. So what we have found is sometimes too much of viscoelastics when you use during the surgery, or leaving out some of the vitreous was the reason. So yes, complications are there. You can have iris tears, non-clipping of the lenses, or breakage of these lenses, and we have also a lot of publication comparing with other SFIOL techniques. But done properly over a period of time, I think you do get very good results. And for on-table complications or in small incision cataract surgeries or in training institutes, I think this is a very good option of an SFIOL along with all the other techniques. So now moving on to the next part of the talk is the CMT Flex IOL. It's a new option for aphakia, so no financial interest. So basically it's a single piece hydrophilic lens with specialized T-shaped haptics on either side. So the whole concept is when you pull out these haptics through the sclerostomy, they just open up and stay there. So this avoids any tucking, suturing or gluing of these lenses. So here again we have a case of an aphakia which was referred to us. So as for any SFIOL, the 0-180 degree marking is very important. So we use the Ashwin's glue IOL marker to mark the 0-180 degree after making the peritomy. So we make partial thickness scleral flaps on both sides. We make a 2 by 2.5 partial thickness scleral flaps using the crescent blade here. So why this 0-180 degrees? Because basically it avoids any tilting of the lens or any torsion later. So 1.5 millimeters away from the limbus, we make a sclerostomy using a 23 gauge needle on both the sides now. So after doing the vitrectomy, as I said, and removing the remaining cortex, so we have specialized T-flex forceps that goes through sclerostomy. The other advantage of these lenses are being a foldable lens, you can make your corneal incisions wherever you want diagonally opposite. So this makes it easier to feed the lens. Initially we were always doing superior, but then you have an angle of 90 degrees that has to be, so this way it makes it easier. So make sure that the T haptic comes out first, so it is easy to grasp it. So now what we call later on after 5 years of learning is we call this as the head-on position. So basically what happens is when this comes through the sclerostomy, the haptics bend inwards. So there is lesser portion of that CMT flex lens that comes out, and that makes it smoother. Initially we were holding the neck here, so it's a bulkier portion, so people used to tell that sometimes during pulling out it slips or breaks and you have to use more effort. So we call this as the head-on position. The second trick is, since it's a single piece lens, inject the remaining of the lens after holding it. So otherwise it again can detach. So make sure you have the trailing haptic at the wound or over the iris, and once the lens is free from the cartridge, then make sure that you pull the haptic out, and then you see a pop and the T opens up. So once that is done, it is literally over. So just a small animation, it can be done with any regular IOL cartridge. But as I said, just make sure that the T is just pushed inwards so that when you inject, the T part comes out first, and that actually makes it easier for us to hold and grasp. So there is no special cartridge or anything that is required. And clear corneal incisions, so if you have an old scleral tunnel, you don't have to open up the tunnel and suture again, so you can make a fresh clear corneal incision, and that's how it's here. So now for the second thing, we use the handshake technique. So using the other Nishi forceps, we usually grab the arms of these lenses. We also have two holes, so that actually indicates which side the lens comes, because we have an angulation, like a 10-degree angulation between the optic and the haptic. So that basically that angulation prevents any rubbing of the iris or any pigment dispersion or glaucoma later on. So once the second hand is exchanged, that is also brought out. So as I already said, because of the specialized haptic designs, there is nothing more you will have to do. However you mark your 0-180 degrees, that's how the lens is going to stay inside these IOLs, and you can see you have nice round pupils. This is just to show you how it is, and we close the scleral flaps. So initially we were actually gluing the flaps and the suture. You can either glue it or you can use your suture or even just cauterize it, because here these haptics are slightly thicker. They are not the 3-piece lens haptics where you might have leakage because you're using a 23 gauge sclerostomy. So you don't have to actually glue it, because the size of those things are make sure that it fits the 23 gauge sclerostomy perfectly. So there's not going to be any leak. So these are some of our studies on UBM just to show how the position of the lens in compared to normal PCIOL or the other secondary SFIOLs, and also OCT images through the sclera just to see the long-term efficacy over 5 years, how these material actually behaves under the sclera, and our publications are out. So the other thing is it can be combined with any other technique, like any SFIOL when you have a traumatic iris, when you want to do a scaffold technique. So this is just another case where there was a trauma and there was like superior iododialysis. So again, as I said, 0-180 degree, the ease is you can actually go vertical, you can, wherever you have the area where you can see. So that's another advantage here. Again, just 1.5 millimeters away from the limbus. As you can see, these holes, some of the surgeons have told me that they use these holes with the dialer when they want to exchange to the other hands. Some of them have been using the Hoffman's pocket to do this and deliver it, so then they don't have to make the flaps. Or sometimes we also do a groove. So basically, as long as the haptics is under the sclera, it is safe and it is better. As you can see, the other side is exchanged and then brought out. At the sclerostomy, there is going to be a slight tug. That is because of the instrument diameter. So what I suggest is you don't actually whack it out, because that again can actually release the hole. Just wait at the sclerostomy end and give a constant pull, and you can actually see it slipping out rather than just trying to pull it out. And then we did an SFT for the superior iododialysis. Yes, for the anterior segment surgeons, yes, it can be done. It's an alternative again. So the last video is going to be that. The only thing is always use an AC maintainer, because for any of these secondary IOLs, the biggest problem is hypotony. So this again, you can see a post complication of SICS in an asteroid hyalosis case. We know that sometimes the bags are weak. So here we're just doing it through the anterior approach. So ideally you should have used an AC maintainer. So, but again, because it was formed and I didn't use a lot of viscoelastics. So again, here we're just making the grooves. We didn't make the full flaps. So there are just various modifications of the same technique. So again, now once the lens is injected inside, I always just open the flap just to make sure when I have the tug and I'm able to see clearly. That's why I lift the flaps before I pull the T junction out. Here again, exchanging the other hand, grabbing either the head or the neck, either way, and they are relatively flexible, so less intraocular damage to the tissues also. And they have a good stretchability also. We have titrated the water content in such a way that you have some amount of stretch that also happens, that prevents any breakage. And always check if you're not sure that is there any vitreous left behind. So you can always introduce tricot and then wash it away just to make sure that there is no vitreous, because post-operatively any CME that is going to come is all because of the leftover vitreous, and also some amount of this tricot actually goes behind and prevents post-operative CME. So that's another advantage of using tricot assisted vitrectomy for all your cases. Yes, complications can happen. As I said, it's common for any SFIOLs. You can have breakage of the haptics, or when you pull forcefully, the other side can slips, or the other things, isn't it? So it's been a long journey from the time of invention. It's been almost 7 years follow-up we have. Thanks to COVID, we had lost 2 years of bringing it into the market. But thanks to Dr. Mohan Rajan, Amar, and everybody who helped me in this journey to bring the lenses today. So thank you once again to everybody.
Oh, very nice, Nivian. I think it's a very beautiful presentation. Sugas, you have a question? Yeah, we have some time for discussion. I think it's a very beautiful innovation. Come to the mic, Sugas. Nivian, come here.
Compliments, Mohan Rajan. Beautiful course, and congratulations to you for very nice innovation. In fact, for most of us, a simpler technique like this would certainly be good. My only question was, in the iris clip that you showed, I mean, the general understanding is, when you want to do a retrofixation of an iris clip, if you have some remnants of capsule, you normally try to get it out, because otherwise, through the capsule and the iris, if you want to enclave, it is difficult. But in your first case, I saw the entire rim of capsule. Whenever I see that, I cannot do it because
absolutely,
lot of thickness. Can you just throw
it's a very beautiful observation. Only people like Suhas can notice it. But I'm just telling you, any secondary IOL, okay? You saw that there are many ways to skin the cat. That's a different issue. But any secondary IOL, please remove the vitreous, number one. Okay? Some of the posterior segment surgeons say that you should do a complete vitrectomy, do a PVD also. It's not necessary. It's not possible for all the anterior segment surgeons to do it. Remove all the capsular cortical remnants. Suhas, I perfectly fully agree with you, because if you have a glued IOL or a sutured, this will go and stick there and produce a lot of adhesions, lot of traction on the vitreous base as well. And iris claw lens also, if you want to have a capsular remnant, you do not know whether it's fixing on the capsule or fixing on the iris. So it's going to be a problem. So remove all that. Make sure that the area is clear completely. If the pupil is small, use iris hooks to dilate, as I told you. Amar also showed that. Use iris hooks to dilate. And the game changer, in my opinion, is not viscoelastics in secondary IOLs. Have a anterior, it's only a fluid into the eye, because that can prevent hypotonia. Because viscoelastic can go and mix with the vitreous, and HPMC can go and mix and produce severe vitreitis, secondary glaucoma, and all these problems can occur. Use either an anterior chamber maintainer, or if you are conversant with your pars plana, you can put a pars plana infusion as well. So anterior chamber maintainer is definitely more, much more better there for an anterior segment surgeons. You can either use a trocar anterior chamber maintainer or the anterior chamber maintainer which Sujata had shown. I have also developed an anterior chamber maintainer with AIOS2025 which is available with just a 23 gauge needle with a biflow. So you can just insert it like that into the cornea. Just make a small tunnel into the cornea and just insert it straight away with the needle. It's called the needle ACM. So all these I think is very important. Ashraf, you would like to make a quick point, then we go to the last talk. We have some time.
A very good observation, really, because I was looking for this case. We cannot put either iris claw lens or scleral fixation IOL without removing the whole bag. It cannot be like this, unless Susan Jacob, I think, invented supracapsular.
I've seen that video, but I feel,
Yes.
but leaving those capsular and cortical remnants there is going, because it produces a lot of adhesions, lot of inflammation,
Exactly.
and you don't want that to happen, because the glued IOL, the problem is we do not know what's happening underneath the iris in the ciliary body area. So better to remove everything, clear it up. That's a take-home message I want to give everybody here. Nivian?
Yes, I totally agree with you. That's the clear take-home message, and that's how we do it. This particular case was a 12-year-old aphakia. We are always used to try to remove the capsular bag using the forceps. When I tried that, it was coming along with the iris, so I didn't want to cause any iatrogenic tears or bleeding, and that's why the entire iris was awake. So as you said, your take-home message is that make sure you clean the bag, the cortex, the vitreous, and then do any secondary IOL implantation. But very rare few cases that sometimes only in the old cases. I don't see anything in the recent cases that we leave it like that.
But CMT flex is something which is, I think, is really a fantastic, in my opinion, a trendsetter. So we go on to the final topic, and then we'll have more discussion as well. Yes. It's routinely with AIOS2025. Routinely available. Yeah. If you contact me, you will get a discount also, because I'll take the commission from this guy. Yeah. No, I actually speaking, because if you ask the posterior segment surgeons, if you say anterior segment surgeon, just remove the vitreous from the anterior chamber in the pupillary area, just go a little behind the pupil as well. As I told you in my presentation, I don't know whether you were there when I talked. Yes, use tricot. Use tricot first. As soon as you have a PCR, put tricot first. Delineate the vitreous. Remove the vitreous first. Okay. Use a high cutting rate for suction of about 150-200 millimeter. All the phaco machines are now equipped with the cutters, with the vitrectomy cutters. 23 gauge cutters are available. You can have an anterior chamber maintainer. You can have a cutter. You can do that as well without any problem at all. It's not a big deal. It's not rocket science. So once you remove the vitreous, then you remove the cortex and the epinucleus. Then you sit back and find out where your sulcus is. Okay? If your pupil is small, try to expand the pupil and see where your sulcus is before you put the lens. Okay? Otherwise, you go for the other options. Either a glued IOL or a CMT flex or iris claw, whatever you are comfortable. I'm not saying that you should do this. Whatever you are comfortable, you can do that. Okay? Hydrophilic. Yeah. Hydrophilic, hydrophobic.
Yeah. So hydrophobic, the material, the main thing is the flexibility. So we are actually working on it, but I think it will not be as easy to get it out, is it? The only disadvantage is for retina people, if they're having silicone oil in the eye, there has been reports of opacification. But for the routinely, for a secondary IOL, we have like a 7-year follow-up data, which is just recently published, isn't it? So the lens is as good as any other secondary IOL, isn't it?
Mohan Rajan,
Yeah.
the one question is that if the patient having the one area is capsule is okay and other area is capsular dehiscence, so can we put a routine lens with one side scleral fixation and other side having a support of capsule?
I have not done it, but I'm not sure, sir. I'm not. Sugas would like to answer because one side you want to fix it.
Other side.
No, but I would suggest that you remove the capsule and fix it on both sides. Yeah, because there can be lens tilt and all those things can be there.
Okay.
Yeah. Anyway, we go on to the final, then we'll take some questions because we're running out of time. Dr. Ravi Shankar does not require any introduction. He's a senior consultant. He has been with me in Rajan Eye Care for more than 15 years. Got a very good experience in cataract surgery and refractive surgery as well. Very good speaker, and he's going to talk to us on Yamane technique and flanged IOL techniques. Okay? Flanged SF IOL. Over to Dr. Ravi.
Thank you. Namaste and namaskar and good morning, dear friends, respected seniors, teachers, colleagues. It's so nice to see you. A big crowd in front of me. Haldipurkar sir, namaste. Thank you. Wonderful masters sitting in front of me. I'm a young guy trying to present these techniques to you at the 40th Asia Pacific and the 83rd Annual Congress of All India Ophthalmological Society. Thank you. Slide.
Next slide, please. It's not advancing. Yes.
Yeah. Happy to be among the stalwarts who are presenting here. And thanks, Professor Dr. Mohan Rajan, for allowing me to be the co-instructor in your course. Thanks a lot. And no financial interest in any of the products, techniques, or the instrumentation spoke or demonstrated in my presentation over here. There are many ways to skin a cat, and the secondary IOL, there are many options, and I would like to say that it depends upon the amount of capsular support or the nil capsular support. You can select any of these, and whichever technique is good in your hands, I would suggest to go for it. Anyway, I'll be talking about only 3 techniques over here. But you have the AC IOL, the iris cloth, the scleral fixated lens, Professor Amar Agarwal's glued IOL, the flanged IOL technique, the Yamane technique, Dr. Nivian's CMT Flex, and XNet from Aravind Eye Hospital. I would always try to talk to my talks always to the beginners and the younger ophthalmologists, because stalwarts have done many surgeries. They can manage and do the surgery at the end of the day fantastically. But for the beginners and the younger ophthalmologists, all these prerequisites are very, very important. A clean, thorough vitrectomy, which was even emphasized by my previous speakers. Triamcinolone acetate is very, very important when you do a vitrectomy. The reason being, gone are the days when you use a cotton bud over the wound area or try to swipe a spatula on the pupillary margin to see if any vitreous is there. Cannot. Triamcinolone acetate is very, very important to visualize the vitreous and the vitreous strand and the vitreous bodies. And every technique has a different micro instrumentation, and very important to have and getting trained in that particular micro instrumentation. A standby IOL is very, very important, because I've seen many of the trainees, when they are trying to learn a technique, the haptic optic junction breaks away. So have a standby IOL definitely with you. A chamber maintenance is very important. A pars plana trocar cannula, of course, very important when the eye is not vitrectomized. And an AC maintainer, when the eye is already vitrectomized, you can have an AC maintainer. I'm talking about the flanged IOL technique, the Yamane technique, and the XNet. The Yamane technique was already shown by my previous speaker. In the flanged IOL technique, the corneoscleral incision is made, a good pocket is opened up for the IOL entry over there. 2 stab incisions are made on the other side, and a good vitrectomy is done to remove all the vitreous from the anterior chamber over there. And a needle which can be a 6-0-proline or a 7-0-proline injected and entered inside the eye on either side. And with the other forceps or the beveled cannula over there, insert the needle, try to pull it out through the stab incision. Likewise, on the other side, insert the needle in the cannula and try to pull it out. And you can try to crisscross that sutures over there. And once it is done, you can flange the IOL like this in the one of the eyelets, and by a monopolar cautery, try to flange it over there. If you can watch on the either side, see how it goes. There's a bulb or almost like a micro lollipop over there, and then insert the IOL inside the eye. And once the IOL is there inside the eye, you can titrate with both the ends of the sutures on the either side for the centration. And once you're sure that your IOL is centered and you've titrated better, cut the suture and with the monopolar cautery, flange it over there on either sides. This is a flange technique. And once you've flanged it, and once then you can just try to tuck inside that groove over there, and your surgery is done, and the IOL is well centered. And this is the Yamane technique, which I don't have to talk much because many people know about the technique already. The very small video, make both entries of the needle. The needle itself holds as a scaffold for the IOL over there. Use the trailing haptic and get it inside the needle and gently pull it out. Likewise, on the other side, use the needle, enter inside, and feed the haptic inside the needle, pull it out. Be gentle in your maneuvers and procedures, and then with the monopolar cautery, try to flange it on either side, and that's the end of the surgery. Looks pretty easy, but all the maneuvers needs a lot of steep learning curve to work on them, and once you're ready with the IOL centration and your surgery is done. This is the X-Nick technique which I would be very happy to present over here. Technique devised by the Aravind Eye Hospital, Dr. Prabhu Bhaskaran. You make 2 side pockets and 3 and 9 o'clock position, and make the corneous clinal tunnel for the IOL to enter. You use the trocar cannula for the vitrectomy. Like all the previous speakers also was very sure, a good vitrectomy is very important. Even a nuclear bit over there can be removed. Even an IOL which is dangling or which is on the macula can also be removed. And there's a 26 gauge needle which is bent at its hub. Enter 1.5 millimeter away from the limbus, go inside, and with your right hand hold the McPherson's forceps to depress the wound over there, and with your left hand try to turn your 26 gauge needle. There it comes out. That's why it's called X-Nit, because it's an extraocular needle insertion technique where you don't have to have the difficulties of an intraocular the suture insertion or the haptic insertion. There goes the haptic, trailing haptic inside the bevel, inside the tunnel of the needle. Gently with your right hand push the intraocular lens inside, and simultaneously with your left hand pull the needle outside, and your IOL is there inside, and push the silicone tab over there into the limbus area over there, and there your haptic is out. And likewise on the other side or the other position, insert the 26 gauge needle, depress the wound with the McPherson's, hold the trailing haptic, tuck it inside, feed it inside the bevel, inside the tunnel of the needle, and gently. This is extraocular needle insertion. And there comes outside. Once you're out, be cautious to hold with the McPherson's the haptic, and then remove the IOL outside. And once it is done, you can just tuck in the haptics into the pocket on the either side. as I told you in the previous case, looks pretty easy and good steep learning curve. Once you start doing a couple of cases, life becomes easy for you, and the patient, in fact, has a good vision at the end of the day. Chief Instructor, do you have time for one more video? If I have time, if not, I can just...
We have time.
Yeah, this would
You
be
have another almost 2 minutes to go.
This is my last video with the Exnic technique. There's an IOL drop over there, IOL sitting on the retina over there. Hold it with your microforceps, gently pull the IOL outside and bring it out to the scleral wound. And then the rest of the things is what the previous video I showed you with the 26 gauge needle. There comes the needle out, the haptic, the trailing haptic feed it inside the tunnel, and gently push the optic IOL inside, and with the other hand pull out the needle outside. This is the same technique which I showed in the previous surgery, and likewise in the other side also do the same thing. Once the haptics are out, you just need to push it inside the pockets, and there it stands safely for life. That's the end of the surgery, and thank you so much for the wonderful opportunity, Chief Instructor Professor Dr. Mohan Rajan, and all the co-instructors and all lovely delegates who were patient enough to hear me in this talk. Thanks a lot.
Thank you, Dr. Ravishankar, for the wonderful talk. I think you summed it up in the sense that the flange IOL, like a MRI technique, or the scleral tuck, the XNet. So, delegates, any questions from the audience, please? Because as I told you, there are different ways of scleral fixation. One is a sutured. Nowadays, we are not using this suture because the suture degrades over time, over a period of time. What happens is the Prolene sutures degrade and the lens dislocates. So, we have started using the glued IOL. Or if you don't want to use the glued IOL, you can use the Exnic technique and do the scleral tuck. Or you can use a flange technique. The flange technique is the, did you show the Kanabarava technique? Sergio Kanabarava, yeah. That's also a very good technique. The flange technique is also a flange technique only. The flange technique, you just use a monopolar cautery, a simple cautery, and try to flange it. In all these cases, scleral fixation, as I told you, take care of the vitreous, take care of the capsular cortical remnants. Okay, that's very important. Make sure that your the anterior segment, that is the pupillary area, completely free of all these things. And use multi-piece. You cannot use a single piece lens. You have to use a 3-piece lens. Okay, the 3-piece lens, what I would recommend normally is a AR40, that is a sensor acrylic lens by J&J, or Aurolab lens, which is also 3-piece, which is also coming in foldable, or the MA60 lens of Alcon. So these are the lenses I would recommend. The Bausch & Lomb, the soft port lens is not available with us. That has got a silicon optic and polyamide haptic as well. So I think these are the lenses I would recommend for these. You cannot obviously do it with a single piece lens. So single piece lens, you cannot do these glued IOLs or any scleral fixation techniques. So that's why you saw the last case Dr. Ravishankar showed. A single piece lens is completely dislocated into the vitreous cavity. We had to do a total vitrectomy, induce a PVD, make the nucleus mobile, make the lens mobile, bring it up and explant it, and then do a Exnic technique of a 3-piece IOL. Ashraf, you'd like to give some suggestions. Any questions from the audience? Please use the mic. Please use the mic so that it gets recorded. Yeah. Ashraf, you can talk. Yes.
Yes. All techniques of scleral fixation, IOL, or retropupillary design are perfect. But always in your challenging cases, prepare multiple methods, because sometimes Yamani does not go okay. So you should learn another techniques like Canaprava. It's a very good retropure artisan. It's one of the good methods. So don't stick to one method. Try to learn one or two or three, because sometimes one method cannot go well. You cannot all situations are not the same. So if you find that you are stuck in one method, shift to the other method directly. Don't insist that you continue in this method.
Absolutely. I think fully agree with you. You have a plan A, plan B, plan C for all these patients when you are having a PCR or when you are dealing with a complicated case. Yes?
So question regarding CMT flex.
CMT flex.
The horizontal part of the T gets, does it get torn away when you pull it out from the scleral?
No, it's a it's a single piece flexible lens. So even if you hold the neck part of it, it comes out to a 23 gauge sclerostomy very smoothly. What we have modified now recently is like what I showed, the head-on position. So basically, when you hold the head part of it and not the neck part of it, the T actually bends inwards when it hits the sclerostomy. So basically, there's a smaller diameter portion of the lens that actually comes out. So that makes it smoother. But even if you hold the neck, and that's what we were doing before, initially when I was doing that before. Just one more small technique is the sclerostomies that we make. Initially, we were making it parallel to the limbus, like how we do for any VR or secondary Iols. Radius. No, now we're making it perpendicular. So the limbus is there, you make the sclerostomy perpendicular. So we make the sclerostomy perpendicular, the T sits like this. So when there are lesser chances that when you're pulling the other side of this slipping inside, even if you make a large sclerostomy. So that is another trick that we have started following now, making it perpendicular to the limbus.
So similar to the shirt button, you know. So if you have a sclerotomy which is horizontal, and this because this T is also horizontal, so it may not sit properly. If you have the sclerotomy vertical like this, okay, then you have a T which is like this. So that will cling on to the sclerotomy very nicely.
Very good example, sir.
Yeah, shirt button. Always think of that. Yeah.
Sir, hi. Just I wanted to know that fixing IOLs is very easy. Suppose there is a scenario in which you have to take the IOL out. So how will you do that? It's a T-hex or a say glued IOL. If the scenario comes that you need to remove it.
So you want to remove a glued IOL?
Yeah, glued IOL or a T-hex.
Yeah. He was talking about the IOL exchange.
Yes, the glued IOL is a very easy way to remove it. The easiest IOL to remove, because it's already the haptic in a tunnel. So you see the tunnel. So you are just removing, slip it, and then from inside you hold the IOL to the side. The haptic will going to go up and bring the haptic out. The optic will come through the main wound and it slip. So the most important to slip both first, to be in that, to feel it's out of the tunnel in both sides. So the IOL is free now. So hold the haptic, the optic, move it to the left side, so the haptic will slip easily from, and you are going to see it. Hold it and bring it out with the optic. The other one will go like this out easy. This is the easiest way to remove the glued IOL.
So next time I'll start showing those. The only instance you will have to remove is if the other thing gets cut when you're doing the second haptic. So that's again very easy. The outside T part which is already fixed, just pull it out, but hold the lens here and then cut it. And again, externally, that's easier if you cut just pull it and cut. And since it's foldable, then you just twist it and you can remove through the same 2.8 millimeter incision. You don't have to extend the incision. That's the only advantage.
I will say something about the Hemani, because the Hemani, it is the difficult way to remove the difficult fixation sclera to remove, because when you do the Hemani, you are planning to embed the knob. So the most important is to bring the knob out. Never ever to hold it from inside and pull. Too much trauma. So if you cannot see the knob, make very small incision in the sclera to reach the haptic, and then pull it out the same side. So once you pull it out, you see the knob cut, and the other side the same. But never ever pull it from inside.
Yeah.
Huge trauma, and sometimes the haptic cut and a small piece is still in this. So
that's a problem. See, because Yamane, the problem is the haptic is forming a tunnel into the sclera. So you have to be a little careful. Ashraf is a very good point. Yamane is a very good technique. The only thing is we are not using it regularly. It's only a personal this thing. The reason why, because in Yamane you are flanging it and pushing it inside. So you do not know how much of haptic is going and sitting inside. It's actually a blind technique. So there can be some pseudo-phacodonosis. Whereas in glued IOL you don't have the or any scleral tuck. You can actually tighten it under your direct visualization. Tighten it on one side, loosen it on one side, and then you can know exactly. And that's why the pseudo-phacodonosis in glued IOL is less than, is very, very less. Almost close to nil. So that is see, if you don't have pseudo-phacodonosis, the incidence of RD, the incidence of endophthalmodonosis, the incidence of CME, all these are reduced. I think, yeah.
Good morning, sir.
One or two questions you can, we have another 5 minutes.
Yeah, very good morning, sir. My question is like for a beginner surgeon, while tucking the iris claw lens, the problem what I mostly encounter is when I tuck it on the right side, like I am a right-handed surgeon. So should I need to switch my hand or sir, I can do it like what I have done earlier with on the left side?
Yeah, let him answer.
And sir, second thing is like I have done a few cases of iris claw lens, but the results were because there were pigment dispersions, and sometimes I have
Which one?
Uh,
Iris claw lens.
Yeah, and sir, sometimes I have encountered some synechia and reactions. So how to like handle the iris gently, sir?
First of all, thank you. You are a young ophthalmologist, and I love questions like this because this is why we are sitting here. For a young ophthalmologist, iris claw lens, it is not an easy technique, okay? But you should learn it. Before you go for a iris claw lens, your way settings, the chair, the microscope, your hand and your arm should be in a proper way. Don't try to put this lens in a position with the microscope you are not comfortable, because as Naveen said, it is like equilibrium between both hands. So if you are sitting not properly, or the incisions are with a big nose, you cannot handle good, you are going to face a problems. So this is very important, very important. Always don't leave the anterior chamber to loose, and don't press on the lip posteriorly.
Yeah.
These are very important tricks if you want to put a good iris claw. Lastly, as also Naveen highlighted, that very fine touch of the iris to the opening. Don't do aggressively.
Okay.
Just small snip, it's going to clip directly. So this is my tips.
Always use the right hand, okay, if you want to do the left side tucking, and the left hand to hold the optic for the right side tucking. It's not a very big thing to use because, and always better in iris claw lens, you can do with the limbal incision also, or a clear corneal, but always prefer a scleral incision. The reason why the chamber does not collapse and the iris does not come out. Okay, if the iris comes out and it becomes a little messy, and pigment dispersion can also be there post-operatively as well.
There is a very nice technique published. Nice technique published.
Yeah, one more question, sir, and we are closing.
For the fixation of the claw, they put a cannula. You pass a cannula from one side opening and bring the cannula outside. So you have cannula bisecting the anterior chamber. So, and it's over the iris. So you introduce the IOL under the iris, with the cannula. It's already inside the
already
iris,
inside.
above the iris. Press, it will going to click. So this is another technique. It was published. It's very nice, really. But
I saw the video also. It is very nice.
Yes,
Somebody
it's
has
very
done
nice
it.
and very easy. Less
One last
manipulation.
question, and thank you very much for all the delegates coming in large numbers. Last question. Yes.
Thank you, sir.
Sir, what would be the best way to explant an iris claw.
Explant an iris claw lens, yes.
Yeah. So I have done a couple of cases. Again, the trick is to hold. See, one of the sides is clipped and the other side is de-enclaves or broke. Hold a firm grip. That is the first thing. So okay, we need these broad forceps. The second thing I do is give a mild counter traction. So I wanted to de-enclave this part. So I hold the lens and I give a mild counter traction. So now it's stretching the iris. And then you use the Sinski and I go in the reverse direction. So from bottom to down, you just dip it and it actually de-enclaves very smoothly without any damage. Yeah, not a chopper, no sharp instrument. It's a blunt instrument. So the main thing is it's under the iris. I hold the lens, give a counter traction, and then from below upwards you just push the iris tissue. You will have to see the iris tissue actually going out. Some of them have said you can use the cutter also in case, so just to that is if you just want to remove the lens.
One quick comment I want to add. The position of the side port is also important. You cannot go clear corneal. You have to go limber or just exterior to the limber. It makes the tucking very easy for iris claw. Thank you, sir. Thank you.